we have Professor Matjaž Zwitter, MD, PhD, Head of the Department of Medical Ethics and Law, Medical Faculty, University of Maribor, Slovenia. His 2 papers on ivermectin for COVID-19, as published in Slovenian medical journal ISIS and in leading newspaper Delo, stirred a vivid debate among medical and lay community, hopefully leading to a change in the current medical practice. He was co-editor of 2 books on communication, Communication with the Cancer Patient, Information and Truth, the New York Academy of Sciences, 1997, and New Challenges in Communication with Cancer Patients, Springer, 2013. He also wrote and published 3 books talking about the medical ethics in Slovenian language, Kanker Jiva Zolozoba, 2018, Medical Ethics in Clinical Practice, Springer, 2019, and talking on euthanasia in Slovenian language, Slovenska Matica, 2019. So our next speaker, last but not least, I think this is one of the most important talks that we would hear today. That is Dr. Professor Matjaž Zwitter. He is the head of Department of Medical Ethics and Law, Medical Faculty, University of Maribor, Slovenia. We talked about the rest of his bio before. He's going to talk about ivermectin and the ethics and the law. So, Dr. Professor Zwitter, welcome.
Ladies and gentlemen, dear friends, after 2 long sessions and 11 excellent presentations, I have the privilege and the difficult task to give the last talk before Dr. Seid concludes our meeting. My basic specialty is oncology. Nevertheless, my main activities now are teaching and research in medical ethics. I'm most grateful to the organizers of this meeting, and especially to Dr. Tess Lori for the invitation to speak about ethical issues in connection with the pandemic, and particularly on the role of ivermectin as a potential drug for COVID. Conflicts are a normal component of every human activity. Without conflicts, we would be a frozen society like North Korea. Yet, it is essential that the rules for resolving conflicts are clear and are respected. A football game is a conflict of 2 teams. Both want to win. They engage the best coach and the best players, develop their strategies and train hard. However, doping or bribing the referee or serving poisoned food to the opposite team are not allowed. Such activities would be illegal and also deeply unethical. In medicine, the situation with regards to medical ethics is more complicated. For Hippocrates, the physician and the patient were the only persons involved. In 1803, when Thomas Percival wrote his classical text on medical ethics, a 3rd figure entered the stage, the pharmacist. Today, every activity in the field of healthcare, in one way or another, touches the interests of a wide spectrum of individuals or groups. In the case of COVID, a patient infected with this virus and his or her physician are clearly not the only persons involved. Patients with other diseases who compete for the same resources, other physicians and health personnel, hospital management, pharmaceutical companies, health insurance companies, healthy elderly, and teenagers, they all have their legitimate interests. These interests do not overlap and may come in conflict one against the other. The COVID pandemic put the spotlight on these conflicting interests. After every significant crisis in human history, we see losers and winners. In every war, thousands or millions of people lost their life or their property, while for some other individuals, groups, or nations, The crisis brought an opportunity to increase their wealth, influence, and power. The same is true for the COVID pandemic. Those who died of the disease or have health consequences due to long COVID are, numerically speaking, a small proportion of the overall number of people affected by the pandemic. Millions of other people feel indirect consequences of the health crisis. Lockdown measures, as imposed by most governments, led to severe restrictions in most areas of our societies. A list of problems and tragedies due to lockdown measures is almost endless, and so is the list of groups of our citizens who were severely hurt by the pandemics. The economic consequences of the crisis will be felt for many years. At the same time, for some segments of our societies, the health crisis brought an opportunity to increase their power and wealth. The first on the list are pharmaceutical companies, especially those involved in the production of vaccines and antiviral drugs. A significant shift of public activities to virtual events, meetings, and education means a fortune for all connected to the growing business of computers, information, and media technology. Due to marked increase in online shopping, Amazon and Alibaba are making fantastic revenues. In brief, this crisis, as any other crisis in the past, leads to a marked turnover on the ladder of the economic, social, and political power. This holds true on an individual level, on the level of particular groups within a society, and on the global level as a shift in power of nations. As we saw during these 2 days, ivermectin appears to be a safe and affordable means to end this pandemic. Yet, every effort has been made to prevent the implementation of ivermectin as prophylaxis and treatment for COVID in the majority of countries. Let us see a brief and admittedly incomplete list of the obstacles. No funding for clinical trials, obstacles to publication, promotion of trials designed to produce a negative result, blocking positive information, releasing false negative information, and biased information from trusted sources, regulatory agencies, or WHO. Starting with clinical research, 2 elements are very obvious: funding and publication. Regarding funding, only 3 trials out of 22 listed by Drs. Bryant and Laurie in their recent meta-analysis, so only 3 out of 22 received support from pharmaceutical industries, and another 3 from the institution. 16 trials, or 72%, received no support whatsoever. And then, when the authors of the trials tried to publish this, they faced another obstacle. Only 7 of the 22 trials were published in peer-reviewed journals. Replying to a survey mailed by Dr. Laurie, many of the authors wrote that the manuscript was returned without any editorial comment or proper review. It's hard to avoid a feeling that for some editors, ivermectin for COVID is a prohibited topic. At the same time, when so many authors of reports on COVID and ivermectin faced such a negative attitude of editors and referees, Journal of American Medical Association published a trial from Columbia which is very informative to go into details. This trial included relatively young patients, median age 37 years, with mild symptoms. All of them were ambulatory. Eligibility up to 7 days since the first symptoms, so some of the patients were already in the phase of recovery. This trial, it seems, was designed to produce a negative or inconclusive result and was probably funded by pharmaceutical companies. We all know about the experience of Dr. Corey with his testimony to the Congress, which was recorded on YouTube and soon afterwards erased. His review paper on ivermectin for COVID passed through peer review and was accepted for publication in Frontiers in Pharmacology. Nevertheless, something very strange happened. 2 weeks later, Dr. Corey got a message from the editor that the paper was rejected. Dr. Hill from Liverpool had a similar experience. His report to WHO on meta-analysis of ivermectin against COVID on YouTube was quickly removed, presumably due to dangerous and misleading information. Without exception, all drugs currently in use against COVID have weaker evidence of efficacy and are more toxic when compared to ivermectin. Yet, no other drug has received a comparable negative promotion. Food and Drug Administration issued a warning to the public against the purchase of unregistered ivermectin and the use of the product for the treatment of COVID. European Medicines Agency advises against use of ivermectin for the prevention of or treatment of COVID outside randomized clinical trials. Furthermore, they warn that side effects could increase with the much higher doses that would be needed to obtain concentrations of ivermectin in the lungs that are effective against the virus. According to WHO, the current evidence on the use of ivermectin to treat COVID is inconclusive. Until more data is available, WHO recommends that the drug only be used within clinical trials. National Institutes of Health wrote that there are insufficient data to recommend either for or against the use of ivermectin for the treatment of COVID. Again, they say that results from adequately powered, well-designed, and well-conducted clinical trials are needed to provide more specific evidence-based guidance on the role of ivermectin in the treatment of COVID. Finally, we have Merck, the company which sold or donated 3.8 billion of doses of ivermectin over the past 4 decades. Merck stated that company scientists continue to carefully examine the findings of all available and emerging studies on ivermectin for the treatment of COVID for evidence of efficacy and safety. They concluded that there is no scientific basis for potential therapeutic effect against COVID from preclinical studies, no meaningful evidence for clinical activity or clinical efficacy in patients with COVID, and a concerning lack of safety data in the majority of studies. Should we blame only the pharmaceutical companies? I don't think so. As I said in the beginning, diverging interests are acceptable so long as the players stick to the rules. We all know that pharmaceutical companies primarily follow their commercial interests. Their slogans, such as "patients' interests are our priority," do not reflect their marketing strategies. We do understand that they are not charities, and that they go for profit. What is to blame, however, is that pharmaceutical companies are using channels other than usual marketing in order to pursue their goals. Influence upon information networks, on medical journals, on regulatory agencies, and on WHO as a prima facie defendant of the public rather than commercial interest, and possibly even on governments, all this is deeply unethical. The same holds true for sponsorship of trials designed to spread biased experience. Such activities are very much like bribery to the referee in a football game. We know that football is not only a game, it is also a big business, but nevertheless, the game has to stick to the rules. And if we accept bribery in football, then all the excitement of the Champions League is lost. And back to medicine, all the enthusiasm of doctors and nurses who are doing their best to save lives of their patients is lost in case they are not allowed to use the drugs which they consider most appropriate. In conclusion, the story of ivermectin, which we have been discussing these 2 days, is only a small piece in the puzzle of current pandemics. Yet, this story is a classical example on what happens if the rules are not respected. In a democratic society, our governments and public agencies should defend the rules and stand behind the public interest. The story of ivermectin is therefore also a story about true or false democracy. Thank you very much. I'll be very glad to hear your comments.
Thank you so much, Professor Zwitter. What an excellent presentation. For me, the last statement, story of ivermectin for COVID, is the story of true or false democracy. What a beautiful way to present this. Thank you very much for clarifying a lot of some of these, the anger towards big pharma. I think the clarity is great, but still I feel that there is a lack of transparency there for the honesty that you asked for. So a few questions, and I'm going to piggyback on Dr. Mehdi's questions as well. So the first question that I have is, and Dr. Zwitter, for you, Barbara Somen from, I believe she would be from Slovenia, they're saying that Dr. Zwitter, how can we approach doctors in Slovenia to prescribe us ivermectin off-label? Any recommendations?
Well, we, in many countries, including Slovenia, it's not an exception. The majority of doctors are still believe what companies and what agencies tell them, and so is the situation in our country. Most doctors simply do not believe that ivermectin, since it's not registered for this indication, is effective. We know that in the past, in my field, oncology, we had every year a couple of miracle drugs, and all of them, without exception, proved to be just false hopes. And some doctors, or maybe many doctors, think that ivermectin is again one just such a miracle drug, which, if properly tested, will be proven to be ineffective and of no benefit. I'm very sure that it's not the case, but I don't know why doctors do not go for the documents. On the web, there are so many documents showing that ivermectin really works. The other problem, of course, is that ivermectin in our country, well, it is registered, but you can't get it in pharmacies. So quite a few doctors and also lay people told me recently that they bought ivermectin from Bulgaria, from Greece, from India. And so I think this is a bad situation when people start using the drug, which is well, it should be regulated. I think we should press on the government to answer the question more briefly. We should press on the government to allow this drug either for routine use or to start a big trial. I'm proposing a trial now for a couple of weeks and pressing on all the buttons of the government to let us start a trial where we would, similar to what Dr. Schwartz showed at the beginning of today's presentations, a trial for early COVID-infected patients, where we would compare ivermectin to placebo in a double-blind randomized trial, and we hope to get at least 1,000 patients. We have a lot of patients, so we can do it, and that would be really an achievement. So maybe that would be a way how to do it. I do support a clinical trial, not just some wide prescriptions.
Got it. Thank you very much for that answer. Dr. Methi, I have a question for you as well. So there is a question from one of the audience members. So are you stating that the UK MDs have the prescribing power to write for ivermectin, and that for fear they have not has been the problem?
I think the short answer is yes. Like I said, I've prescribed ivermectin recently. I've prescribed it every year since 2005. I prescribe it because it's, in my opinion, risk-benefit analysis and that of my team. I think the slight difference with prescribing it with COVID is it's the first time that I'd be doing that as a minority, because as has been described here, my belief that it works on the risk-benefit analysis is not the majority opinion of doctors in Scotland. But I think that minority position will change very quickly if I start prescribing it, patients get better, other people watch this conference and realize that just following recommendations from the WHO and the EMA is not how we practice medicine. We routinely do drugs that we don't wait for approval from the WHO on a case-by-case basis, on a compassionate basis, on the expert opinion risk-benefit analysis of patient and doctor autonomy. Absolutely. I think we can prescribe it, and when we prescribe it, the NHS will have to source it, and when the demand goes up, they'll have to find better sources. There's currently lots of ivermectin in ID units around the country which are not being used because we don't have a lot of tropical diseases in Scotland. Right. That's not really the issue. The issue is that we're not prescribing it and we're not making the case.
Got it. Thank you very much for that. And one more question to each of you, and then we'll move towards the next steps. So Dr. Methi, first to you, the prescription to cohorts that you have been giving ivermectin. So the question is, what were the relative results compared to other patients? Did you do any analysis?
So I work in an area that probably has the lowest incidence of tropical diseases in anywhere else that I've worked previously. So the numbers were less than 5. So I don't really want to make any scientific conclusions from that. But I am hoping to link in with other centres in Scotland, UK-wide, so we can compare the outcomes of patients who've been given ivermectin for this reason with appropriate kind of case control data. But anecdotally, we only gave a low dose once, 0.2 milligrams per kilogram once, and anecdotally, patients had an improvement in the oxygen requirements at 24 hours, but then they often had a deterioration thereafter, which would fit with the idea that we probably need to give a higher dose and more often. And it also fits that perhaps in severe disease, ivermectin is less effective than it is in earlier disease, and that's really we should be before hospital.
Got it. Thank you very much. And one more question for you, Dr. Professor Zwitter. So Barbara Simone says, thank you for your answer. There is a lot of Slovenian ready to help with the pressure on the government. What can we do? And if I can tag on my question on top of that as well, that when WHO comes out and uses, cherry picks some parts of the studies and says, hey, this is not useful, don't do it. How, not only just one country's government, how do we create a pressure on such organizations as well? What is the way to move forward?
Well, for WHO, I don't know. I really don't know it. I don't think that they are a transparent organization, and they are probably, at least for individual doctors, we can't do much. I think what we can do is just show in every single country that they were wrong, and then they will have to admit that they are wrong. They will not do it otherwise. So if one country after the other makes a clinical trial and proves that this drug really works, then within a couple of months we can change the whole situation. So
yeah.
again, yes, please.
Well, personally, I do not think that clinical trials are the way to go, because there's enough evidence. And I think if one is going to then go and try and conduct clinical trials in every country when we already have enough evidence to show that ivermectin probably reduces deaths by a huge amount, I think we are actually complicit and we're playing their game, because their game is calling for these, and what that is doing is killing more people, kicking the ball down the road further, and in the meantime causing a lot of harm. So I think we really need to stand together and say enough is enough. We have enough evidence, and we have to work. Perhaps it is country by country, and we focus our efforts on that country to persuade the authorities so that we get the ball rolling and we get ivermectin to all the countries we can as quickly as possible. Randomized trials take a long time. Then at this rate, we're not even managing to get our trials published. Look at all the trials that are on the preprint service. So I think there's an agenda that we can't beat by playing the game that they want us to play, that is controlled by big pharma.
So that is a very keen observation, Dr. Laurie. Absolutely. We have enough data already. I was talking with Dr. Pierre Corey last night, and we were talking about ivermectin, and he used a statement which was beautiful. He said, for ivermectin, the efficacy results have become proven, period. We're done. Now is the time to start seeing how do we make ourselves and doctors, and how do we get to a point where we can start using it. So Dr. Laurie.